Okay, so this is our first time trying to do a recorded PowerPoint, so definitely please be patient with me. Hopefully, I don't keep running into technological difficulties. Um, and hopefully it goes smooth. But anyhow, give me feedback if you can, if you get to watch this before we see each other on Monday. If not, give me feedback when I return to see how it is and anything I can fix. But with that being said, I'm going to try to do hematology really quickly because we were unable to finish this in class yesterday. And as an overview, hematology is really the study of blood and blood-forming tissues. And there are three important blood cells that are formed in the bone marrow that we kind of discussed a little bit yesterday. The red blood cells, which transport oxygen to your cells, and your white blood cells that destroy foreign cells and help distinguish self from non-self, and your platelets, which produce or promote hemostasis and prevent blood loss. So today we are going to mostly just talk about iron deficiency anemia, sickle cell anemia, hemophilia, and idiopathic thrombocytopenia purpura, which is ITP for short. Aplastic anemia, I'm just going to kind of touch on. I'm not really going to talk about too much because, like I said yesterday, a lot of the management is very similar to a leukemia patient, which we covered in depth yesterday. So when you're thinking anemia in general is really just a decrease in the number of red blood cells. It reduces obviously their hemoglobin content too, and reduced volume of packed red blood cells. So at the end of the day, you really just need to determine the cause. What's causing your anemia? Because it could be from an increased loss, like overt bleeding, hemorrhage. Or it could just be a problem with production and that the production is too slow. These are the lab values that you just kind of want to be cognizant of as a reminder. These are the Rady ones that we use for children's. And do take some time if you don't remember to refresh yourself on what each one of these actually measures. So, iron deficiency anemia. This is an anemia where we're deficient on iron, right? So we talked about how red blood cells are important to carry oxygen to your tissues. And for that to happen, hemoglobin is very important and necessary to actually get the oxygen carrying capacity. But iron actually is largely or dependent on how much hemoglobin can be produced. So for children, it's the most common actually to see in infants and toddlers, so as well as adolescents, but starting from the beginning, around about 6 months of age, the babies will start to lose their maternal iron stores, and thus will be needing to get it more from their diet. So it could be from a decreased loss of iron intake, that they're not taking iron fortified formulas, or periods of increased growth rate, which is infancy as well as adolescence, or poor utilization of iron by the body. Most commonly, this is actually seen in the 9-month well baby checkup, and also when they will routinely check for anemia, either 9 months or the 1-year appointment. So what you'll see as an assessment for your patient is typically an overweight milk baby. So why is that? So around 1 year of age, we talked before that you can switch your baby from taking formula and or breast milk at this time. They can start drinking cow's milk. So it is recommended that they have full vitamin D, full fat milk at this time. But sometimes these babies are drinking too much milk. And once you start switching to cow's milk, there is not very much iron in it like they were thinking with their formula. So that's why you'll sometimes see an overweight milk baby. You'll see your patient look pale, have some pale mucous membranes potentially, maybe irritable, tired, fatigued. Like I said, usually you see this between 6 and 24 months, most commonly toddlers and female teenagers as they start menstruation. So diagnostically, you'll see a decreased hemoglobin hematocrit. You'll also see a decreased serum iron level and an increased total iron binding capacity. For treatment for these patients, first 6 months, really, the baby's exclusively breastfed, hopefully. I mean, we're encouraging breastfeeding. So the goal is, and the recommendation is that for the first 6 months that parents exclusively breastfeed, and mom takes a prenatal vitamin, which has an iron supplement in that. The other thing is they add iron to fortified cereals and food. Nutritional requirements, we can include meats, eggs, and dark green leafy vegetables. We may have to give iron supplements, and limit the intake for an infant definitely below 32 ounces a day. For an older child, so over 12 months of age, 24 ounces of milk max a day. You may need to limit activities and provide rest for them if they're severely anemic, and definitely iron supplements. So when giving an iron supplement, it is really important that you make sure to provide education for your families. Typically, iron supplements are dosed by 3 to 6 milligrams per kilogram per day and are divided in 3 doses. It's really important that we encourage our our families to administer the doses ordered. Give on an empty stomach. Use dropper to avoid teeth stains. Do let them know stools may be tarry and have increased constipation related to this, and may color their stool black. Don't give with dairy products. Max effect, like I said, is 3 divided doses a day. Overdose can be very fatal, so it's really important that we make sure that we are childproofing and putting these iron supplements in a safe location, because you can get heavy metal poisoning. Over 6 months of age, you can give iron with any type of citrus fruits, orange juice. It will help to increase the absorption. So the next thing is going to be sickle cell disease. There's an interesting link here. Let me see how it's going to work online. I haven't done this yet. I'm starting now to get fancy, so we'll see how this rolls here. This is a really interesting kind of journey of a patient.
When the other kids used to go outside and play, I would try to do that, then I'd come home and very sick and have to be back in the hospital.
17-year-old Alexandria Young of St. Louis, Missouri, has sickle cell anemia, among 72,000 Americans with the disease.
Among all Americans, approximately 1 in 1,500 to 1 in 2,000 newborns will be diagnosed with sickle cell disease.
In people with sickle cell disease, their red blood cells become deformed, turning sickle-shaped. The bone marrow tries to make more red cells to make up for the loss, but can't keep up. causing anemia. Their new shape keeps them from moving properly through the body, and the misshapen cells can jam up and stick to the walls of the blood vessels. These clumps cut off oxygen to healthy tissue, delaying a child's normal growth and causing fatigue and extreme pain.
It's like a hammer beating at you like for a long time.
I never heard anybody scream that high and just well out, and we were like, what's wrong, and man, she had it so bad where her eyes just roll back up, just roll back, and she's just in pain, just screaming, yelling, and we didn't know what to do.
And I thought she was just talking in her sleep or something, but she had mentioned that she was ready to go home. And I said, Alexandria, you are home. We're home now. She said, no, Mommy, I want to go to heaven. That's my home. And
Okay, deep breath.
Dr. Michael DuBon has been Alexandria's hematologist since she was 4 years old.
Any headaches, double vision?
Fatigue and pain are not the only issue in sickle cell disease. Essentially, every organ in the body can be damaged by the lack of oxygen. The kidneys, the heart, the eyes, and now we know even the brain.
In addition to pain, probably the most feared complication is that of a stroke.
and right here is a silent stroke.
When Alexandria was 12 years old, a brain scan revealed that she had indeed had a stroke.
I was very scared because I thought only older people would have a stroke and not 12-year-old.
Silent strokes like Alexandria's were not even recognized until a small research study in the 90s was conducted to better understand sickle cell disease in children. MRIs showed that strokes occurred when the misshapen cells got stuck in the brain and cut off oxygen to it.
Certain locations of the brain control your movement. They control your motor ability. Okay. There are other areas of the brain that if we removed it, it wouldn't alter your movement at all. It would alter your ability to think. The area of the brain in the frontal lobe is the area of the brain that's more likely to have silent strokes. So most of the children with silent strokes, they're actually walking around, interacting with their family in a fashion that makes people think that, yeah, this child is doing well.
Dr. DuBon has Alexandria on a research protocol, hoping to stop the strokes. Monthly blood transfusions, called apheresis, remove Alexandria's damaged red sickle cells and replace them with red blood cells from a healthy donor. The hope is that the healthy new red blood cells will prevent her from having future strokes. Dr. DuBon monitors Alexandria's condition closely, including annual brain scans to look for further damage.
I pray constantly, about Alexandria, that she hasn't had another silent stroke.
The young family won't know the results until their next visit to Dr. DuBon.
How are the clinic? Straight A's.
Staying on this protocol, it has dramatically improved her classroom performance, dramatically just improved everything in her life is just completely turned around.
Whew, it's just like a switch, man. It just totally changed her. She started to grow.
Congratulations. That's fantastic. Straight A's.
How was the test results?
We had the MRI for brain performed a couple of days ago.
It's to make sure that she hasn't had any new episodes of silent strokes.
That's right. And the answer is no. There's no evidence of progression. So it's all done and it's really good news. Okay?
Okay. So they already talked about quite a few things in that video that we'll kind of talk about here in a moment. But really, sickle cell disease is where normal adult hemoglobin S is partly or completely replaced by abnormal sickle hemoglobin S. So you can see the picture, and it's just, I liked that video because I liked how they showed in the blood vessel, but it's very similar to that. Here is another picture. So sickle cell is a hereditary autosomal recessive disorder. So if one parent has sickle cell anemia and the other doesn't, all of their children will have the sickle cell trait. Now, if one parent has sickle cell anemia and the other has the sickle cell trait, there will be a 50% chance of the baby having either sickle cell disease or the sickle cell trait with each pregnancy. Now, when both parents just have the sickle cell trait, they have 25% chance, 1 out of 4, of having a baby with sickle cell disease with each pregnancy. It's very common, primarily affects persons with African and Eastern Mediterranean descent, but it can occur in many other ethnic groups. This is just a genogram of when both parents have the sickle cell trait. So pathophysiologically, what's happening, and they did start to describe that in the video, in that the red blood cells start sickling and it increases your blood viscosity. This causes blood flow obstruction, tissue hypoxia, tissue ischemia. And whenever you have ischemia, that is what's causing the intense pain that is often associated with this disease. Increased red blood cell destruction is what causes the chronic anemia. This is a slide of what it looks like on the red blood cells. Before I actually go into this, I'm going to kind of back up, so sorry about that for 1 second. There's one more way that I like to look at this in terms of the pathophysiology. And since we know that hemoglobin S can sickle in times of hypoxia, it's important to note that through acidosis and dehydration, this can happen. Also, the hemoglobin S, it can return back to normal after reoxygenation. However, if it's frequently getting into a sickling crisis, sometimes the sickling is irreversible. So the most common sites for sickling include the lungs, the spleen, and the brain. Those are your most common areas, but throughout your body, really, you can have sickling anywhere. And now that I'm talking about this, I think that I actually have a picture of this down the way, so we'll hold off on those areas. But do note that the most common areas for sickling are the lungs, spleen, and the brain. Diagnostically, we can find out prenatally before the baby is born if potentially they have sickle cell disease by the chorionic villus sampling or an amniocentesis. Newborn screening also covers this. And a hemoglobin electrophoresis differentiates trait from disease. Oh, and here it is. 3 conditions causing red blood cells to sickle: low oxygen concentration, acidosis, and dehydration. This is the picture I was referring to, and my point being here is that sickling can happen anywhere in the body. While I did say that the most common sites include the lungs, the spleen, and the brain, I think that it's very important to be aware of all of the areas that can be affected. So if you think of all the organs in your body, I'm going to list a few of them here, but spleen being one of the most susceptible sites is really important. So what can happen is an acute sequestration crisis where you get the obstruction and the blood pools in the spleen in large quantities. So this can be because your blood is kind of getting stuck and pooling in your spleen. It's taking away from the intravascular space in the rest of your body, and you can get a really quick drop in blood volume in the rest of your body and tissue. So it's an emergency and can result in shock. Now, the lungs are also another place, and the most common being acute chest syndrome that patients may experience. This presents with a fever, cough with sputum a lot of times, intense pain, shortness of breath, and decreased O2 sat. The liver, for the liver, you will see decreased liver function and necrosis. Your kidneys are another area. You can have ischemia, hematuria, enuresis, inability to concentrate urine. Your skeletal system, you have poor perfusion to the bones. You could have osteoporosis, lordosis, kyphosis, osteomyelitis from that. As the video said, it also can lead to stroke, so you can have obstructions in your central nervous system and your brain. Also, cardiac, it can cause cardiomegaly and make your heart work harder, and you can lead into heart failure. Additionally, skin integrity is decreased and decreased growth rate related to chronic hypoxia and poor circulation. So the clinical manifestations that I was kind of just referring to, these symptoms usually start around 6 months. I tend to like to break things up into systems because if you really understand that sickling can happen really anywhere in your body, depending on where the obstruction and ischemia is caused, will kind of help you understand what you might be seeing with signs and symptoms in your patient. I'm not going to say these again because I just mentioned them. But for a vaso-occlusive crisis, this occurs when the blood flow to the tissues is obstructed by the sickle-shaped RBCs, when you get the hypoxia and the ischemia. So really, it's very important for you to understand and be aware and educate your families with sickle cell what the precipitating factors are. And the precipitating factors are infection, dehydration, hypoxia, trauma, and stress. So when your patient comes into the hospital with an acute vaso-occlusive crisis, often what you're going to see is severe pain. Severe, I mean just wrenching, unspeakable pain in your bones, joints, abdomen. May have swollen joints, hands and feet, anorexia, vomiting, fever. You may see the hematuria, obstructive jaundice, visual disturbances, and potential CVA. Chronic signs and symptoms of a vaso-occlusive crisis include respiratory infections, retinal detachment and blindness, systolic murmurs, renal failure and enuresis, liver enlargement and failure, spleen enlargement, and an increase in infection. There's actually a lot of times where the spleen needs to be taken out, which increases their risk of having frequent infections as well, being seizures, skeletal deformities as well, which all kind of go along with what we were talking about earlier in terms of understanding systems and organs affected. This is kind of a diagram here that shows you, again, all of the types of things that we were just talking about. Just another way to kind of lay it out for you. I added some nursing diagnoses that would be common for your patient with sickle cell anemia. I think it's a good idea to kind of understand what some nursing interventions would be related to these diagnoses and priorities. So go ahead and kind of brainstorm what you think you would do in terms of nursing interventions for these problems. I'll give you kind of a minute. So some of them, obviously, for pain, we're going to be giving a lot of pain medicine. For altered tissue perfusion, it'll be good to teach them to avoid physical exertion, emotional stress, and even actually low oxygen environments such as airplanes or where there's really high altitudes and any known sources of infection. May need to administer blood transfusions as ordered. May need to give oxygen as well. So fluid volume deficit is very, very, very important. They need to get rehydrated. They are going to be on lots of IV fluids, need to be making sure we're monitoring strict I's and O's and calculating what their fluid needs are. And definitely observe for signs and symptoms of dehydration. For the risk for infection, I think we talked about this already a lot last week. So we do need to note that they are going to be at increased risk for infection, as especially if your patient has needed to have their spleen removed. So ensure that the child's immunizations are up to date. Report any signs of infection to the physician immediately. And ensure adequate nutrition by providing a high calorie, high diet, or high protein diet. Additionally, during a sickle cell crisis, the patient will need to rest, may need to be on bed rest. Like I said, hydration and pain management are huge. Electrolyte replacement to correct any acidosis. Additionally, I forgot to mention that it is common to be on prophylactic antibiotics with this. This is a patient drawing, actually, of how he felt sickle cell pain was, and he wanted to try and describe what the pain was like, because like I said, I think it's often just like no words to really describe how painful this is. So for sickle cell anemia, complications and preventions, there is a transfusion program patients can have every 4 to 5 weeks to maintain the hemoglobin around 9 to 10. Hydroxyurea is also an oral medication that promotes production of fetal hemoglobin in bone marrow. The fetal hemoglobin does not sickle and binds to oxygen easier than adult hemoglobin, but we have to use this with caution because it has been shown to be carcinogenic. It does alter DNA synthesis and can interfere with normal growth. What else? Bone marrow transplant can be. But really, the prevention is really the primary goal. We really want to avoid other people with viral and bacterial illness. Make sure that we are providing prophylactic antibiotics for those with, due to splenic dysfunction, and that they are vaccinated, like I said before. We do need to make sure that they maintain adequate hydration. Also outside, and they may need to increase their rest periods in hot weather as well as how much they drink. Also during febrile illness and marked activity. Encourage sports also with rest periods. Some good ones would be maybe baseball, swimming. Swimming is good as well. I already started, I'm sorry, on this side. The only thing I think I did not mention is heat to affected areas for swollen joints. Another thing there that I should have mentioned that I want to mention before we kind of move on is that we should recommend that our patients with sickle cell anemia do get a medic alert bracelet. And advise maybe genetic counseling before they are doing pregnancy again. We also do need to make sure that we are assessing the psychosocial kind of aspect in terms of coping, because it can be really difficult, and living with this disease, and also helping in terms of family. And since stress is also a huge kind of prediction reason for sickle having a vaso-occlusive crisis, it is really important that we do help and see how they're coping and how they're managing the stress in their lives, and give them additional support and resources out in the community. So now hemophilia. So hemophilia is one of the other bleeding disorders. So there's going to be a couple. The remaining things that I'm going to talk about are actually part of the bleeding disorders, and you'll see. So the body depends on a complex mechanism to ensure proper clotting of blood, basically. So platelets and several clotting factors are required to really make this happen. Platelets can be decreased for several reasons. So for hemophilia, the one we're going to talk about is that where clotting factors are often deficient due to a genetic cause. So hemophilia is it's a broad classification. It's a term for a group of bleeding disorders from a congenital deficiency of specific coagulation proteins. Most are X-linked recessive factor 8. There's hemophilia A, and it's manifested mostly in males and carrier females. The mother is the carrier and transmits it to her male children. So hemophilia right now, currently it affects about 1 in every 5,000 male births. Currently there's about 20,000 males in the United States living with a disorder. Let's flip over. This is actually a kind of Venn diagram, showing what will happen if father does not have hemophilia, but mom is a carrier of the hemophilia. So 50% chance that the son will have hemophilia, and 50% chance the daughters will be a carrier of hemophilia. So females can have DNA testing for the trait. You'll also see a prolonged PTT and factor-specific assays that will ID the specific deficiency. So people with hemophilia have low levels, basically, of either factor 8 or factor 9. The severity of hemophilia that a person has is determined by the amount of factor in the blood. So what I'm saying here is that there's kind of a wide variety in terms of the severity of illness. The lower the amount of factor, the more likely it is that the bleeding will occur, which can lead to serious health problems. And hemophilia A is about 4 times as common as hemophilia B, and about half of those affected have the severe form. Hemophilia affects people from all racial and ethnic groups, but the most common being a factor 8 deficiency. So the signs and symptoms of hemophilia, like I said, they'll be manifested differently according to the severity and how much factor the patient has in their blood. But we'll see prolonged bleeding, bleeding into the joint cavity with hemarthrosis. The early stage, you'll see the stiffness, tingling, achiness in the joint. Later, you'll see decreased range of motion and signs of inflammation. A major risk factor would be intracranial hemorrhage, excessive bruising, spontaneous hematuria, hematomas. You'll see swelling, pain, limited range of motion. This is just a picture of hemarthrosis. So what we want to do really is to prevent potential complications. So from internal hemorrhage, transfusion reactions, shock, and death. A lot of the kiddos do have frequent blood transfusions, so we do need to be cognizant and aware of that. So really the thing for when we're trying to treat, the best thing to do is prevent, right? So for hemophilia, we really want to just provide what the patient is lacking. Treatment is dependent on severity. For those with mild hemophilia, they may just have DDAVP, which increases your factor VIII. You may have moderate, which you may need replacement therapy only when bleeding occurs or to prevent bleeding that could occur when doing certain things. Severe hemophilia is where they're on a regular schedule of factor VIII, and oftentimes these patients are just at home and they administer their own factor VIII in their IV. There is a large spectrum in terms of severity of hemophilia, so I just kind of want you to make note of that. So for that reason, a lot of the treatments are a little bit different. Amicar, it inhibits breakdown of fibrin use, and this is more for mild, but for mouth and trauma surgery. So if you know that you're going to go in and have a surgery, we'll typically take something beforehand because to help with the bleeding. The outlook for children with hemophilia has been really greatly improved by the availability of the transfusion therapy that I was talking about in the previous slide. In the past, many children with factor VIII deficiency died in the first 5 years of life, but today children with moderate or mild hemophilia can lead normal lives. This is an example of someone injecting his own factor. So we do give blood transfusions for severe bleeding. Fresh frozen plasma is given to expand blood volume. Packed red blood cells are given to increase oxygen carrying capacity. It is important to rest, ice, use compression and elevation for hemophilia management when we're having hemoarthrosis. So just remember the rice. Severe bleeding may need aspiration because the body may not absorb it all. Pain management, biggest thing here is that you cannot give any NSAIDs because we're already having an issue with bleeding. We do need to take breathing precautions and make sure that we're doing active range of motion and not passive. If we're doing passive range of motion, we can cause a rebleed. Some bleeding precautions to keep in mind are those with toddlers and that are severe hemophilia. We do need to be careful. As we said, intracranial hemorrhage is a very severe complication of this disease. So we need to make sure that we're teaching family to safety proof their house, lots of padding, probably wear a helmet as they're learning how to walk. Physiologic assessment will include a complete health history. We need to know all history of bleeding episodes. Definitely assess joint pain, swelling, or deformities. Neurologic assessment, psychosocial assessment is huge as well on this. So we need to assess patient and family coping and the family's ability to manage the procedures and treatment at home. So you want to focus on preventing and controlling, like I said, the bleeding episodes. So close supervision and safe environment, like I said before. Shave with an electric razor and apply pressure to superficial bleeding for at least 15 minutes. Limit joint movement, manage pain, provide emotional support. Definitely do want to refer to community resources. Now, ITP is the immune-mediated platelet destruction caused by platelet antibodies. So this is an autoimmune process. Antibodies bind to plasma membrane of the platelets, causing them to be removed from the circulation in the spleen and the liver. So really, they think this is brought on by viral infections, or drugs such as heparin. It can happen as well. And collagen vascular diseases like lupus. There are acute and chronic types. Acute is really the majority of the cases, about 80% of the cases. It is self-limiting, and it does resolve in days to weeks by itself. Chronic, really, we call it that when it's lasting over 6 months. But complete recoveries can still definitely occur. This is a picture here of multiple petechiae and purpura. So for ITP diagnostics, really we just need to get a history and physical count. Sorry, I was reading those two things together. We need to get a history and physical. The platelet count can be, is when it's less than 20,000. Hemoglobin will be normal, and the white blood cell count will be normal. This is another picture of an infant with ITP with large ecchymotic areas. Poor little guy. So for ITP management, we really just do restrict activity. We can give IVIG since it is an autoimmune kind of process to try to block that autoimmune destruction of platelets. Prednisone is basically the main kind of treatment for this. Typically, they're given a long dose of prednisone, and that treats it in itself over a couple weeks. For those with really chronic and severe form of ITP, a splenectomy may be needed since the platelets are destroyed in the spleen. Platelet replacement, not usually indicated unless intracranial hemorrhage occurs. So for nursing management, we just do need to focus on assessing and controlling the bleeding. So we need to do vital signs, LOC, look at the petechiae and the purpura. Patient education, we'll be making sure that we're using Tylenol for pain and fever. We cannot use Motrin, right? No NSAIDs. Avoid contact sports. Teach signs and symptoms that can indicate bleeding, especially neuroassessment. We need to be teaching a good neuroassessment for potential intracranial hemorrhage. Aplastic anemia is the last one, and we're not going to talk too much about it, but it's really the failure of the bone marrow to produce adequate numbers of red blood cells, white blood cells, and platelets. In about 75%, there's an acquired and a congenital form of aplastic anemia, but about 75% of the cases are idiopathic. They have absolutely no idea the cause of this. For about 25% of the time, they have found a linkage to potentially toxins, radiation, and chemotherapy, treatments for other autoimmune diseases such as lupus and rheumatoid arthritis, and pregnancy and infectious diseases. So when you have aplastic anemia, what the labs reveal is leukopenia with marked neutropenia, thrombocytopenia, and anemia. The bone marrow maceration will be yellow and fatty bone marrow. So some signs and symptoms, really, they're dependent on the degree of bone marrow failure. You'll see petechiae or purpura, bleeding, pallor, fatigue, weakness, and tachycardia. just like I said before, similar to the cure with child with leukemia. So pretty much in review, just kind of saying, for iron anemia, we didn't have enough iron, so not enough hemoglobin. For sickle cell anemia, the hemoglobin was replaced by hemoglobin S, which is the sickle kind, leaving decreased function for red blood cells. And then the hemophilia, the clotting factor was the problem, which caused bleeding. For ITP, it's an autoimmune attack against your own platelets. So that's why you have a low level of platelets. And then aplastic anemia is also thought to be autoimmune, where your bone marrow just doesn't produce enough red blood cells, white blood cells, and platelets. So it's kind of in summary. Have a couple questions here for you guys to end with. So we definitely can't give iron from a medicine cup. So hydration and pain management. So mobilization of the affected joint. So provide a safe, age-appropriate environment. And that is it.